The continuous curvilinear capsular Rhexis, first described by Gimbel and Newhan in 1991, is still the most critical step for phacosurgery even today. Let us understand the basics of the capsular Rhexis with the help of some diagrams. When we are doing a Rhexis, our tearing force is usually directed parallel to the pupil margin. Our Rhexis also goes in the same direction because of two factors. Firstly, the zonular forces which hold the capsular bag firmly in place while we are tearing the capsule, and secondly, prior to starting the Rhexis, injecting viscoelastic into the anterior chamber pushes the lens behind and helps to neutralize the forward pressure of the lens and vitreous. These two factors ensure that there are no other vector forces at play and the Rhexis goes on smoothly in the direction intended. But for example, if while doing the Rhexis, say the surgeon presses on the wound, the viscoelastic will leak out and the lenticular upward force will now overpower the downward force. This will lead to an outward vector force along the anterior capsule towards the equator. This changes the direction of the Rhexis vector because an outward vector now comes into play and the Rhexis will start to run out. Now let us see a case example. So this is a mature cataract with a shallow anterior chamber. We can see that the patient is squeezing the eye. The Rhexis is initiated, but due to constant squeezing of the patient, we see that the Rhexis is starting to change direction and going outwards. I stop here and come out and try to repressurize the chamber. Let us pause and study this scenario. So the current direction of the Rhexis is shown with this red arrow here, which is shown to be going outwards. Our immediate reaction will be to pull inwards so that the Rhexis doesn't run out, and forwards so as to propagate the tear. This blue arrow here shows our direction of pull. Now I have used a real vector calculator to see the resultant vector of these two red and blue vectors, which is shown by this black vector, and adding these two forces we see that this resultant black vector is still going outwards. This will only worsen the situation. Unfortunately, this is exactly what I do. I pull inwards and forwards, and as expected the Rhexis has now gone further out to the zonules. So what next? A lot of surgeons would give a cut at this stage and finish the capsulotomy, but as we know, a free flap during phaco can be a recipe for disaster. If we understand the basics of vector forces, we should be able to complete the Rhexis every single time, no matter how far out it has gone. Let us see what we can do in this situation. Our Rhexis has gone far out, as can be demonstrated by the red arrow here, somewhere around 125 degrees. Now we want the Rhexis to come in this direction of the black arrow, which is the resultant vector, which is around 200 degrees. So what should be the direction of our force to get the resultant vector in this desired direction? Applying this situation to the real vector calculator, the result shows that the direction of our force should be opposite to the angle of the runout Rhexis, showing to be around 290 degrees here. This should be our direction of pull, opposite to the direction of the runout. Now if we pull in this direction, we are also pulling on the zonules inwards. The zonules are not firm but elastic in nature, hence on pulling them, the entire bag and equator may get pulled forwards. But usually the zonules provide enough counter traction to our pull, and eventually the tear will get propagated in the desired direction. So this is exactly what I do. I pull opposite to the direction of the tear, and after some amount of struggle, we can see that the tear has changed direction and is coming inwards. The Rhexis now can be completed. We can see the difference between a completed Rhexis and a discontinuous capsulotomy here. Let us see this second case. This is a myopic eye with a deep chamber. I have started the Rhexis, but as you can see, since the upper eyelid is pressing on the superior half of the eyeball, my view is getting obscured. Before I realize it, the Rhexis has gone outwards. Now the first thing I do is I try to get a better view. I can see that the Rhexis is nearly at the zonules. This is even more difficult than the previous situation because this is a sub-incisional runout. But even at this point, it should be salvageable. I apply the same principles. I pull in opposite to the direction of the runout. But as I'm trying to grab the capsule, we can see since it is sub-incisional with a deep anterior chamber, the wound is getting pressed, leading to egress of OVD. With OVD leaking out, as I explained, there will be an additional outward vector, and this vector exponentially increases the Rhexis vector magnitude. So even with maximum pulling inside, the resultant will still be outwards as shown by this vector calculator. So one very important point, in order to prevent OVD egress, always enter from the site away from the extension. Hence I make a new wound on the opposite side. Now I try pulling opposite to the tear direction. I pull and pull and pull harder and harder, but in a controlled manner. Eventually, the Rhexis does change its direction and comes inside. I now complete my Rhexis. So as it can be seen, even in this case which seemed very difficult, using the right principles, the Rhexis was completed and we can achieve an in-the-bag IOL fixation. Just to summarize, what all have we learned from this video? Always pull opposite to the direction of the runout, pull hard and keep pulling. Do not let the chamber shallow while doing so, and the Rhexis will always come back if you understand the vectors of it. Thank you for your kind attention.